Hi, hello, it's official. We are live. Okay, I'm Sophie and welcome everybody to next IVF webinars by Egg Donation Friends. We solved the issue. We spent much time on it, but we did it. So yes, we are doing this webinar today. Thanks to our partners also who help us doing what we do. And we are here together with Dr. Natalia Szlarb from IVF-Spain, and we will be talking about stimulation protocols and possible circumstances of something not going okay. And not taking any more time and wasting your time anymore, we are going to do the presentation. Dr. Natalia, are you ready?
I'm more than ready.
Yes, I'm happy. Let's do that.
Sophia, thank you very much for keeping cold blood till the end and putting a lot of effort to having us connected. I don't know how I signed up to webinar as one of the attending, and then you can imagine that we had to clear computer memory, cookies, and everything to make it happen. But to cutting this long story short, I'm glad that you waited, and I'll be more than happy to discuss with you the stimulation protocols that are used by majority clinic and what in IVF-Spain we do differently to achieve this success rates. So I hope now I'm going to move the slides properly. Yeah, so the problem is that the older we are getting, the lower X quality we are achieving. The modern society wants women to study, to develop their careers, to be independent. But the problem is that our biology is designed to have children before we are 35 years old, and then our fertility drops down dramatically. So here you see how many cycles patients are undertaking in order to achieve successful pregnancy. So there are some women before 35 years old that need a support of assisted reproduction, and about 1.5 cycles are needed to achieve a pregnancy. When somebody is between 35 39 years old, 3 cycles are needed. At the age of 40, 1 cycle is needed, because this is the moment where usually patients give up and then go for egg donation. So here you see pregnancy rates in this orange curve with patient-owned eggs. We women, we are designed to have children until this moment, until 30, 34, 36. And then at the age of 44, 46, 10 years later, where we still feel young and amazing, our fertility drops down dramatically. So at the age of 44, basically the only way you can get pregnant is through egg donation. And in the blue curve, you see the pregnancy rates due to egg donation, which are age independent. So how does it work naturally? In 1 cycle, we generate 1 egg that can get fertilized. But the goal of assisted reproduction is to freeze as many embryos as possible of somebody who is young, before 35 years old, to preserve your fertility and certain pregnancy rates. That's why assisted reproduction developed IVF protocols, which are called controlled ovarian hyperstimulation, where at once we are able to generate more eggs and more embryos, so we can transfer them in fresh cycle. And then if this doesn't work in the fresh cycle, we can transfer the good embryos in following frozen cycles. So the problem that we face through our age is genetical quality of our eggs. Why the success rates, why the pregnancy rates due to our age are getting down? Because our eggs quality is lower and lower. So the number of genetically abnormal eggs and embryos that we generate are age dependent, and then we're going to define due to our age how many genetically normal embryos, euploid embryos, blastocysts we are able to generate. So every patient that comes to IVF-Spain on the day of first appointment gets examination of your ovarian reserve. To ovarian reserve, according to the American College of Obstetrics and Gynecology, are 3 A's included: your age, your AMH, and antral follicle count. Age, the number of eggs and embryos which we generate, which are genetically normal, we gonna discuss. Antral follicle count, according to American College of Obstetrics and Gynecology, we need to see 6 antral follicles to give you a chance to try with your own eggs. So this kind of ultrasound is usually performed by gynecologists subspecialized in reproductive medicine, where you have to have a very good ultrasound and a very good orientation, where you see the ovary with a transvaginal scan from up to down, and then you count the antral follicles, the potential eggs that you see in patients' ovaries. Age, to cut it as short as possible, when somebody's 20 years old, 30 years old, not older than 30, 80% of all the eggs that we generate, the embryos, the blastocysts, day 5 embryos, are genetically normal. When somebody is 35 years old, 50% of eggs are good. So sometimes embryos are good looking, but are genetically abnormal. You have to imagine that at the age of 35, you can generate 5 blastocysts, but every other one, so means 2 of them, will be healthy. Antral follicle count we discussed. AMH, it's a blood examination that what I like about IVF-Spain is that the result of AMH we basically have in 2 hours. Patients come in the morning, they have a blood drawn, and then in the lab upstairs, which we have, in 2 hours we know your AMH levels. And then when your AMH is more than 2 nanogram per milliliter, in the mild middle dose IVF cycle with 225 units of recombined FSH, you are able to generate about 20 eggs. When your AMH is between 1 and 2, the number of eggs is less, between 10 and 15. When AMH is under 1, then the number of eggs which you are going to generate is less than 10. When your AMH is 0 point something nanogram per milliliter, we know that you are basically slowly a candidate for an egg donation. So the patients that I see from Germany, they sometimes hear first time in their lives what AMH is. Patients from UK always complain that they have to go from GP to specialist, and then again to GP to have this test done. The problem is in reproductive medicine is a time, okay? That we can wait, we can allow ourselves to wait when we are 30, 35 years old. At the age of 35, there's nothing to wait for anymore. We just have to get working to generate as many eggs and embryos as possible. And at the IVF-Spain, in one day, basically, when you come, you have a full evaluation, and you know if your AMH, antral follicle count, your age, allows us to work with your own eggs or not. Ideally, for reproductive medicine, to work with your own eggs, we want a patient to be 40 years old or younger than 40 years old, because then the number of genetically normal embryos which we generate is higher. Antral follicle count should be more than 6. AMH level, the good results are expected when your AMH levels are more than 2, between 1 and 2, 0.7 and 2. The results are not as good, but still it's doable and advisable to try with your own eggs. When AMH is lower than 0.7, we know it's going to be extremely difficult to get pregnant with your own eggs. We recommend egg donation. If patients are stubborn, they want to still try with their own eggs, then we allow them to do it. We see if we are able to develop their embryos to the blastocyst stage. If yes, then we test this embryos genetically. And when you have one genetically normal embryo, blastocyst tested at IVF-Spain, the pregnancy rate is more than 70% per transfer. So here we have two kinds of patients that are quite challenging that approach IVF-Spain. Are patients which are high responders, or patients which are defined as polycystic ovary syndrome. We're going to differentiate both groups. General population and low responders. So in general population, the literature that I was reviewing to prepare this presentation shows us that if I use a long protocol or a short protocol, the pregnancy rates are lower, 27 or 23%. The difference is 3%. So if I were to do this kind of cycles at IVF-Spain, I'll probably lose all the patients. The data that we have available is on day 3 embryos. The goal of IVF-Spain, which stands out, is develop embryos to day 5, test them genetically in the protocol which is safe for you, which doesn't cause ovarian hyperstimulation. And majority of our patients in IVF-Spain undergo short antagonist protocols, and that's why IVF-Spain is OHSS free clinic. You can imagine that since 2013, I work in IVF-Spain, and I have never seen any hyperstimulation using antagonist protocol. The price that you pay for using antagonist protocol is that when you trigger your ovulation, the egg retrieval has to be done 36 hours after triggering. Your receptivity of endometrium is not as good as it should be. But in IVF-Spain, we are not interested in transferring in fresh cycles, because genetical testing takes about 10 days. So majority of embryos or of euploid blastocysts are transferred in the following frozen cycle. When I, communicate this approach to UK patients, they are quite surprised. They are coming from a country where everything has to be transferred fresh, where HFEA grades the quality of a center depending on the results in fresh cycles. In the United States or in Spain, where I work and I guide IVF-Spain as a medical director, we have higher success rates with frozen genetically normal blastocysts than with fresh ones. And then the pregnancy rate per transfer with this approach is about 70% per transfer. So here, the advantages of antagonist protocol. Why have we decided in IVF-Spain use antagonist protocols? Because the time where patients is on medication is shorter than in long protocols. Basically, patients are putting 7 days injections in their home country, and then for the second part of a cycle from Monday till Saturday, they are in IVF-Spain. In IVF-Spain, every patient after first appointment gets a medication plan. So, day by day, how your treatment is going to look like. And still, there are a lot of papers published about using birth control pills or not using birth control pills before a cycle. In IVF-Spain, having very good experience with egg donors where birth control pills synchronize the antral follicles. We put this experience to our patients. So majority of our patients before treatment, before a cycle, are either on birth control pill or on estrogens and progesterone pre-treatment. They have bleeding, which we can adjust to your plans, to your vacation, whenever you have time and you're ready to work with us. The first 7 days you put injections in your home country. The following 7 days you are in Spain, where we see you in Spain every 2 days. We plan egg retrieval. When you are synchronized like this, egg retrievals usually happen in Alicante between Wednesday and Saturday. We are ovarian hyperstimulation free clinic. So basically patients the same day can fly back home without any complications. Your embryos are being developed to day 5, tested genetically, and then in the next cycle we transfer your frozen genetically normal embryo. Through antagonist protocols, the lower dose of gonadotropin is required, less cyst formation is being described, and reduce risk to almost zero we achieve through antagonist protocols. So when we review literature, the antagonist or long agonist protocols, the pregnancy rates with J3 embryos are the same, but in IVF-Spain, we are not focused on developing embryos to J3. We want blastocysts. And the pregnancy rates are a lot higher through this approach. So again, reviewing literature yesterday, I found a very interesting article from 2 years ago. The same patient were examined through the Turkish group, and in the first approach, there was a group using antagonist protocol and then agonist protocol. What has been described that in the same person using two different protocols in two following cycles, that the pregnancy rate, if we choose antagonist or agonist protocol to the same patient, the pregnancy rates are not affected at all, which allows us to summarize that the protocol that we are choosing is not a key to successful pregnancy. The key to successful pregnancy is to know what I do with these eggs and embryos to give patients higher success rates and to give it as safe as possible for the patient. So that's why in IVF-Spain, the protocol that we develop is two-step procedure. So the first step is focusing on eggs and embryos development. And this is the moment where on the day of the first appointment, patient gets a medication plan. So the medication plan is adjusted to your lifestyle, to your plans. As I said, treatment with birth control pills or mixed estrogens and progesterone, bleeding, 7 days injections in your country, 7 days injections in Alicante, blastocyst development, genetical testing, embryos are getting frozen. We trigger with Procrene, with low-dose agonist. You have to know when you run this kind of cycles that sometimes you can generate 20 eggs. So you are not interested in transferring this kind of in this kind of cycles, because the dose of the levels of estrogens that your body is producing is too high. It's making your endometrium growth in a bad, unphysiological way. So that's why we prefer test embryos, blastocysts genetically, and then you have to know as a doctor how to make this kind of cycle as safe as possible for your patient. So majority of patients are triggered with low dose agonist. Antibiotic is given that you do not develop any infection. And we also support patients when we generate as many eggs with blood clotting medication that improves blood clotting. So out of 700 this kind of cycles that we perform every year, maybe once every 2-3 years we have somebody with complication which is bleeding. We do not have hyperstimulation, so this makes antagonist a key to our eggs and embryo development process. When this has been achieved, the patient again is put on a substitute cycle. Means after egg retrieval we administer for a couple of days progesterone. After stopping of progesterone, you have a withdrawal bleeding, so we can monitor your period like we want to. And when you have a period, we start the endometrium growth artificially through hormones. We grow your lining. We mimic with artificial hormones your natural cycle. We put patients 15 days on Progenova, estrogens. Day 10, we recommend the scanning your country. 5.5 days with progestin, vaginal intake, and the transfer. So basically, the second time when you're flying to Alicante is just for 1 day for frozen embryo transferred with the euploid embryo. So two-step protocol of IVF-Spain is 1 week for eggs and embryos development, 1 day for frozen embryo transfer. And then the pregnancy rates are 70% per transfer. After 3 consecutive transfer, your accumulating pregnancy rate per cycle is 90%. So basically, we know if we have generated 4-6 euploid embryos, we have a chance to give you a probability of 2-3 children in your lifetime. So when we play smart in 1 cycle, we can achieve entire family planning where we have embryos to transfer in the following cycle after egg retrieval. And then patients quite often are coming back to us 2-3 years later, and we have embryos frozen to transfer in 2-3 years for the second, third child, which our patients like a lot, especially when you come to IVF-Spain, you are 35, you have 5 genetically normal embryos, and it's pretty amazing to see the same patient 5-7 years later, when number of genetically normal embryos which you generate is so low, is 10% only, but you are transferring embryos of somebody that you have been 7 years ago, where the embryos were better, were easier to achieve. So now the challenging cases in IVF-Spain, as I said, standard population, there is data about day 3 embryos. I hope soon we are going to have data about day 5 embryos and pregnancy rates. Polycystic ovary syndrome, as you can imagine, I work slowly 20 years in gynecology. So when I was doing my residency in Berlin, 20 years ago, definition of polycystic ovary syndrome was just to do an ultrasound, see a certain picture of the ovary, and it was enough to say that this ovary looks polycystic. So the criteria for polycystic ovary syndrome have been reviewed a couple of years ago at ESHRE in Rotterdam, in the Netherlands, where there are 3 criteria which are defined, and 2 of them have to be fulfilled in order to define a patient as polycystic ovary patient. What are the criteria? Of course, the ultrasound ovary picture, which it's called in German medicine. I know that there are German patients listening, Perlenschnurkette or pearl collier. Actually, when you do ultrasound of this ovary, you see how the follicles lay down at the surface of the ovary. So it makes them look in a very special way, and we have to count more than 12 such pearls, such antral follicles in the ovary to fulfill the number 1 criterion. Number 2 is testosterone level, which has to be higher than in the range. And then FSH to LH ratio, which has to be 2:1. And 2 of those criteria have to be fulfilled in order to define somebody as polycystic ovary syndrome. We cannot mix 2 definitions, polycystic ovary syndrome and high responder. High responder is somebody who has just a lot of antral follicles, more than 12 antral follicles in the both ovaries. In order to be polycystic, you have to have a picture of high responder and either high testosterone or FSH-LH ratio, which is out of range. Okay, so in order to differentiate PCOS from high responder, we need a picture in ultrasound, and extra criterion has to be audited. Then the protocols for polycystic ovary syndrome, which I remember from school, from Berlin and from Detroit, from America, where oh my God, when we perform IVF cycle, it's very easy to hyperstimulate this kind of patients. So let's give polycystic ovary patients as low as possible dose of recombined FSH for an IVF cycle. And then what we were seeing is that this patient developed poor quality eggs, low number of embryos, that the pregnancy rates are very, very low. That this cycle, when we have this kind of classical approach, they do not have a good outcome. So the luxury that we have in Spain is egg donors, which have amazing ovarian reserved. And then the protocol, the ANTAGONIST protocol, which we use for donors, we started using for PCO patients. And what is interesting, that polycystic ovary patients, when they are treated with 225 units of recombined FSH, my mom, who was a professor of gynecology, when she listens to us, she probably has a heart attack. When we allow ourselves for this kind of cycles, what we see is that this patient generates us 20-25 eggs. What we see is that these eggs really are not as good quality as in standard population. The fertilization rate for this kind of eggs is lower than in the standard population. What we see is that the number of blastocysts, it's usually lower than in the standard population. Out of 20 eggs, they usually generate 7-8 blastocysts. And then age independent, we see how many of these embryos are genetically normal. So IVF-Spain uses ANTAGONIST protocol as standard protocol for patients with polycystic ovary. And there has never been a hyperstimulation of patients with PCOS or high responder in IVF-Spain, because the ANTAGONIST protocol is safe for you. When you trigger a patient with low dose agonist, which is Procrin 0.4, you stop a production of all estrogens in this woman body in this cycle, and you will never have a hyperstimulation. Embryos are developed to day 5, genetically tested, and transferred in the next following frozen cycle with a pregnancy rate 70% per transfer. So in IVF-Spain, we developed protocol for polycystic ovary syndrome or high responder patients, where the pregnancy rates are the same as in every other cycle where genetically normal euploid embryos are transferred, which for me was pretty amazing. Now, when we see the pregnancy rates with day 5 euploid embryos, we see that when you have a smart doctor who knows how to not hyperstimulate the patient, why to give antibiotic, why to give medication that supports your coagulation, especially when you generate 20 eggs. So these are the pregnancy rates, 70% per transfer that we achieve. We're not interested, in IVF-Spain, we are not interested in transferring fresh day 3 embryos and achieving 20% pregnancy rate, either with antagonist or agonist cycle. This is not a goal of reproductive medicine that we perform in Alicante. So we were talking about patients which are blessed through a lot of eggs and embryos that at once they can generate, and in one cycle we can cover entire family planning. On the other hand, we have patients that are coming to us which have low AMH. Low AMH is under 2, very low AMH is under 1, that have less than 6 follicles and are older than 35 years old. I always say to these patients, if your AMH is under 2 nanogram per milliliter, you have to work double. Means we allow your body to show us your work, and we perform one cycle, one IVF cycle, one controlled ovarian hypostimulation cycle, as we discussed, 2-step procedure, and we see how many blastocysts you are able to generate. If in this kind of cycle you are able to generate us 2-3 blastocysts, we are very happy for you. But we know that especially when you're 40, your euploidy rate, number of genetically normal embryos, is 20-30%. It means that out of 3 blastocysts that I have, only 1 is genetically normal when you are 40. So what we do is we do something called embryo banking. We generate 2-3 embryos in one cycle. We let your body recover. Of course, we plan everything. And then in the cycle in 2-3 months, we do again ovarian controlled hyperstimulation. We generate 3-4 embryos more. So we bank them. We bank blastocysts from one cycle and blastocysts from the other cycle. So you worked double, you had 2 cycles, and eventually you have 6 blastocysts. So you have the same chance as somebody who is blessed through high AMH to achieve the same number of genetically normal embryos when you work double. And then the magic number for embryo banking cycles are 6, 8 blastocysts. And then we see out of the 6 blastocysts at the age of 35, 37, 4 are good, 38, 40, 33, 3%, 1/3 is good. At the age of 41, 42, 70, 20% embryos are good. At the age of 42, only 11% of embryos are good. So age-dependent euploidy rate we have here. So I recommend everybody to freeze your genetically normal blastocyst when you are 35, 37 years old. If you do not have a proper partner, my mom was famous for saying that Prince will never come to your life. You have to raise him. So if you have somebody you can invest to raise, but it still needs time and you are not sure, at least freeze your eggs, because you can imagine every other egg in this age is genetically normal. So when we do not put any technology, and we transfer day 3 embryos, these are the pregnancy rate which we achieve in patients which are older than 35 years old. When we have the same patient and we work hard, the goal is euploid genetically normal embryos over 90%. This is the cumulative pregnancy rate per cycle, means after 3 transfers, when we generated euploid embryos, these are our pregnancy rates. Egg donation is standing out. I always say to patients, you know what, I don't care if this blastocyst is from my eggs, your eggs, or donor eggs. As long as it's euploid, as long as it's genetically normal, your pregnancy rates are sky high. So the key word is the blastocyst, is day 5 embryo. I always I always explain it to patients that day 3 embryos, they have just 8 cells, day 5 embryos, 200. So if somebody makes this jump from morula stage to day 5 to the blastocyst stage, it's amazing that you still have this X quality that allow us to develop good embryos, but then embryos in certain age groups are still good looking. We develop blastocysts, but there is no test that allows us to look at the embryo and tell us which one of them is genetically normal, which one is healthy, and then we have to perform genetical testing to differentiate this good-looking blastocyst. So the cycles, the ideal cycles that we have are cycles of young patients over about 30-35 years old, or donors, where at once we can generate 16-20 eggs. The number of blastocysts, it's usually 50%. Out of this number of eggs, we have this number of blastocysts. So out of 16 eggs, when everything is perfect, I expect 7-8 blastocysts. In IVF-Spain, the exclusive egg donation gives you a guarantee of 5 day 5 embryos, and then I've seen a lot of PGS cycles, a lot of cycles with genetics and day 5 embryos. This euploidy rates are always surprising me. Sometimes the same donor in one cycle has all embryos genetically normal. The same donor one cycle later on has just one genetically normal embryo. Okay, so I think genetical testing of egg donation embryos will also be a future standard test to differentiate the embryos. So we talk a lot about what has gone wrong in your previous cycles. There's nothing you can do. There are some centers, there are some laws in some countries which we have to love the way they are. And if in your country only day 3 embryos are allowed, or majority of clinics around you grow embryos only until day 3, this is something that could have gone better. That blastocyst, genetical testing of blastocysts is crucial. We have a lot of patients that in their countries they have given up because they have low AMH, and then we have to work double, do embryo banking. A patient with polycystic ovary syndrome, I see sometimes a lot of cycles with clomiphene. I see a lot of cycles with low dose of recombined FSH with poor quality embryos, poor results. In IVF-Spain, through this antagonist protocol, we avoid hyperstimulation, we avoid complications, we develop embryos to day 5, we test them genetically. And as I say, I don't care if you are a polycystic ovary patient, or you are a high responder, or you are a low responder. As long as you generate me genetically euploid embryos, the chance that you'll be pregnant is 70% per transfer. The more embryos you have, the better for you, the higher cumulative pregnancy rate. And then if you are young, 35, and you have a lot of good genetically normal embryo, in one cycle we have entire family planning, which is pretty amazing. Now, sometimes you transfer genetically normal embryos to an amazing looking endometrium, and still patients do not achieve pregnancy. And then we recommend uterus lining biopsy, because we see that your implantation window is moved, that 70% of all the patients that we have need 5.5 days progesterone to open implantation window. There are some patients that need 6-7 days progesterone to accept blastocyst. So In IVF-Spain, we do not wait for recurrent implantation failure. We do not wait for you to fail 2-3 transfers with euploid embryos. No way. After first transfer, when we see that it has not been working, if you have a negative pregnancy test after first transfer with euploid embryo, before we transfer again, uterus lining receptivity testing is performed, which is done through endometrium receptivity map. And then we defined exactly your window of implantation. We defined how many days of progesterone you need. For patients that do not develop blastocysts, we allow you to do this kind of cycle just once in your life in IVF-Spain. And then instead of having a blastocyst after cycle with your own eggs, we see that the embryos that you generate on day 5 have 2-3 cells. They do not have the body of the blastocyst. Then we inform you that we have nothing to transfer, that your egg quality is poor, and then we have to move on to egg donation. Egg donation is the final step in reproductive medicine, which we can offer you. We generate genetical mother, genetical father, and psychological and physical mother, and this quite often brings balance to families that underwent a lot of cycles that were not successful, and they eventually they want a baby at home. So in IVF-Spain, the first egg donation cycle is usually without genetical testing, because we know that in our statistics, the euploidy rate of embryos are high, are 75, 85%, depends on the month. So majority of patients do not, in the first egg donation cycle, perform PGS. In the second egg donation cycle, when time to pregnancy has to be as short as possible, these are the average euploidy rate that were published by ATA in 2012. We see that the older we are getting, the lower number of genetically normal embryos we are generating. So at the age of 43, 44, majority patients undergo egg donation. So egg donation in Spain is allowed since more than 30 years. So Spain, from all the European countries, has the longest experience in egg donation. It's anonymous, means I can only tell you age and blood type of a donor when you are pregnant. According to the Spanish law, we have to generate a child that will explain the combination of you and your husband, and then your egg donor and your husband. I always say to patients, they have to find you a twin sister, somebody who looks like you, has the same color of hair, color of skin. So when we meet one day and your child will run around us, everybody has to think that you are a genetical mom. So we have more than 500 donors available for you. Where from? We speak regularly to students. We speak, we teach them. We teach them about their fertility, about this, that they have to go to gynecologist once a year to do the smear test. We teach them that before 35 years old, they have to have a first child. When I teach them this, everybody's laughing at me. But you know, in my age, you do not care anymore. You just want to do what's the best medicine has to offer to your patients. So there's a lot of young women that are coming to IVF-Spain. They do social freezing. They do freeze eggs for themselves. And there's a lot of them that decides to be our donors, that decide to make this world better. And if they decide to be our donors, we offer them social freezing for free. This is where we have donors from. They are in 4 groups. Phenotype 1 are girls with blue eyes, phenotype 2 green, phenotype 3 brown, phenotype 4 girls from Asia and Africa. We have donors from Asia. We have donors from Africa. Me being from Detroit area, I differentiate girls from Ethiopia, I differentiate girls from Congo, I differentiate girls from Nigeria. So we have donors for all. We have twin sisters. We have all potential donors for these ladies. We have to make sure that the process is safe for you, means that your donor has to be examined for infectious diseases, hepatitis B, C, HIV, syphilis. Your donor has to be examined for genetical diseases. We test donors for 27 most common ones, like cystic fibrosis, muscle dystrophy. Psychiatric evaluation is obligatory. There are some diseases in medicine which you cannot exclude through lab results. Yeah, a psychiatrist has to come and say, if you have schizophrenia, if you have depression, if you have personality issues, if you're taking drugs, you cannot be a donor in IVF-Spain list. In the second step, you have to describe yourselves. How tall are you, you and your partner, color of hair, color of skin. We ask you what is important for you, which characteristic of yours your donor shall have. We ask you if you would like to match your blood type to the donor or not. We teach you how to communicate to the child and the family that the child is from egg donation. We put your data to the computer. We have a facial matching system, shows me the shape of your face, eye, nose, mouth, shows me 20 best donors available for you. In the third step, all the doctors, we have to sit down together once a week. I show my colleagues my patients, they show me their patients, and then democratically we agree all, Esporua, Rohel, me, Herrera, Alvarez, and Pac, through different backgrounds, we eventually decide, we see patients in their different mother tongues, and Herrera shows me her French patients, or her Spanish, I show my German, my British, and then we eventually decide who will be the best donor for you. So there are a lot of eyes involved in your donor choosing process. So traditional donor selection is through the phenotype, through the way you look like. Genetical donor selection, we have people that are coming to us with different diseases in their screening test. There are people undergoing, there are different screening tests available on the market, and we match your donor to you that you are not curious of the same genetical recessive diseases. We are clinic very advanced in genetical testing. I receive a lot of patients from different countries, African cases with sickle cell disease, thalassemia, patients. Not long ago, I had somebody with multiple endocrine neoplasia, type 1. So if you are carrier of a genetical disease and you don't want your children to be a carrier or to be affected, in IVF-Spain, we have a good collaboration with good genetical labs where basically we do your informativity test from your blood. We know what kind of mutation carrier are you. Each mutation in genetics has its number, and then we can test your embryos, that embryos are not affected or not carrying the same mutation as you do. There's a list in Spain which allows us not to ask bioethical committee for certain diseases like cystic fibrosis, muscle dystrophy, but some other diseases we have to ask the the bioethical committee for your embryos to be tested. So don't be afraid to contact us. Don't hesitate. We'll be more than happy to help you. In all the cycles that we perform in IVF-Spain, the key word is a blastocyst. The second keyword is euploid blastocyst, genetically normal ones, okay? This gives us a lot higher pregnancy rates. In egg donation cycles, there's one program called Exclusive Egg Donation where we offer you a guarantee of 3-day 5 embryos, Exclusive Plus Egg Donation, 5-day 5 embryos. So basically 90% of all the patients with this kind of embryos are pregnant with the first donor. So I think that's it for tonight. I'll be more than happy to answer all your questions. If we will be running out of time, please do not hesitate to drop an email to contact@ivf-spain.com, and then I'm more than happy to answer them through email. Thank you.
Thank you a lot, Dr. Natalia. Thank you for the presentation. And yes, indeed, we have a lot of questions. So,
oh, wow.
Yeah. So, and the first one I will take and display is this one.
Mm-hmm.
Yes. Yes. Now, I had a failed cycle with donor eggs in April with IVF-Spain. I have 1 3BB and 2 5BBB blast frozen. Is it possible to have 2 blasts transferred on the next round to increase the chances of success? I was age 46 in March.
Claire, we do not recommend double embryo transfers in egg donation cycles. Why? Because the pregnancy rates with single or double embryo transfer are comparable when we talk about blastocysts. The only problem is when we transfer 2 embryos is the twin rate. The chance that you will have twins is more than 35%. We have to be aware that twin pregnancy is always high risk pregnancy for you. Means you have to go to the doctor more often. And what are we afraid of? We're afraid of preterm delivery. Means that the children are going to grow quickly, and the uterus cervix, this is something that closes uterus at the bottom, is going to dilate, and you might lose both. Then if we see that your cervix is dilating, we forbid you to work. And you can imagine that I remember still working from Berlin, cases where we were admitting somebody to the hospital at 20 weeks of pregnancy, and this poor mom was staying in bed until the end of pregnancy, usually 36, 37 weeks. We were performing C-sections and twin pregnancies. In Europe, nobody delivers twins anymore. Normally, they all underwent C-section. So these are the basic complications that twin pregnancy is facing. So before I say yes to you, you have to be aware of this kind of complications. I would highly recommend you to perform endometrium receptivity assay to know what is your window of implantation. Maybe this is the problem why the first transfer didn't work, and transfer 1 embryo again to the womb that I know what to expect from, rather than double embryo transfer.
Thank you a lot for the answer, and we will take the next question. Hello, I'm 38 years old and I have gone through 2 failed IVF cycles in the USA. One of my ovaries is not responding. My AMH level is 0.3 to 0.4, and in both cycles my AFC was 5 follicles in the good ovary. What protocol would you recommend for me next? I plan to do another cycle in the next 6 months.
As you have heard, in IVF-Spain, we use antagonist protocols, but the dose of recombined FSH, the dose of medication that you inject, has to be adjusted to your AMH. Your AMH is low, madam. Yeah. Means I will never generate 20 eggs out of this kind of AMH. Usually, when you give high dose of hormones, you're going to block the ovaries, and the cycle outcome is going to be poor. So low FSH, low AMH, low FSH injections, low recombined FSH injections. So you have to speak to your doctor. Maybe it's time to introduce something different and stimulate you with 150 units of recombined FSH and see how many eggs you are going to develop. When you have that low AMH, we have to be aware that sometimes follicles are growing, but they are empty. How do we know this? When you perform the controlled ovarian hyperstimulation cycle, when you inject, we also monitor the level of hormones, estrogen, progesterone. And when follicles are growing in the ultrasound and estrogens are growing too, you have a chance. You have a chance to have egg in these follicles. If follicles are growing and estrogen levels are low, means that these follicles are empty. Yeah, means you can save your time and money and cancel this kind of treatment. Yeah, and then 38 years old, you're trying hard, you had 2 IVF cycles, you are 1 more ahead. There's a moment in your life where after 3 cycles, you were not able to achieve your goal with your own eggs. We'll be more than happy to help you with egg donation.
Thank you for explaining this as well. This will be the next one. Hi, I'm a patient of IVF-Spain, age 31, with AMH of 5.99, done my first own egg stimulation last month. 12 follicles collected, 10 eggs were matured, 7 were fertilized, but only 2 managed to blast. This is a bit frustrating, to say the least. This is going to be our first cycle to date, as we were in different clinic before, and this is our first in IVF-Spain. We were suggested to us to do second embryo banking, which we agreed to do. Is there a chance that we will get more blast on our next stimulation in August?
So when we see this kind of cycles, we have to see what kind of protocol has been used and what can we improve. If this was a problem of an egg, if this was a problem of a sperm, patient with low, you have a low blastocyst rate. Out of 7 eggs, I expect at least 4 blastocysts. The blastocyst rate should be 50%. In your case, it's only 2. Okay, so we have to see what can we do differently. And then I know, how IVF-Spain works. If you have end result in IVF-Spain, you are discussed in the medical committee. There are 4 doctors that, have to sit down together and say, we give you lower dose of hormones because eggs quality was poor, and through lower dose of hormones in the following cycle, maybe we can win less eggs but better quality. Maybe there has been something with your husband's sperm quality, and this has to be improved. Let's see how the cycle goes. 2 blastocysts, it's not the ideal result, which I will expect from somebody with your AMH and 31 years old. But if you do 1-2 cycles more, at the end, you have a chance to generate 6 blastocysts in your life. And with 6 blastocysts in your age, 4 of them are genetically normal ones. So your cumulative pregnancy rate is over 90%. So you have a chance to make it happen in your life. But it looks to me that you have to work harder.
Thank you for this answer as well. And now we have less specific question, but what percentage of people do not achieve a genetically suitable blastocyst for transfer?
It's a very good question. It depends on your age. When you have, ladies at the age of 35 years old, I very seldom say, madam, you have no blastocyst, or madam, they are all genetically abnormal. Okay? So in this age group, it almost doesn't happen. If we have patients over 40 years old, and they generate as blastocysts, 20% of them are genetically normal, but 80 are abnormal. So this 80% will have a transfer cancelled. At the age of 44, 45, 99% of all the patients that we have genetically abnormal embryos. So 99% of them will receive an answer, madam, I have nothing to transfer to you. So the percentage of people that do not achieve genetically normal embryos is their age related. And you can imagine in IVF-Spain, 1200 cycles, 50-50, 50% donation, 50% IVF. So 600 IVF PGS cycles a year. What we see is, as I say, age dependent, the number of genetically abnormal embryos we generate.
Thank you a lot for giving us this answer as well. And we will take a look at the next one. Hi, I am 38. I have 2 failed cycles in London. I have low AMH around 0.4, and my husband has low sperm. I am considering IVF-Spain, but I am not sure if I should try with my own eggs again or go for donor egg sperm.
Okay. You have to imagine that young eggs of a donor can correct imperfections of sperm. Sometimes the count is low, but still there's a good motility, there's a good morphology. So maybe when we switch egg donation, switch your egg to a donor egg, this will be the first moment which will allow us to achieve blastocysts and give you 70% pregnancy rate per transfer. I wouldn't like you to go the direction we're going to exchange both at once. No, you have low ovarian reserve, madam. AMH 0.4 means in American medicine low ovarian reserve. There is no, I hate the expression, the European expression, your AMH is good for your age, or your AMH is bad for your age. No, AMH is more than 2. You have good ovarian reserve. AMH between 1 and 2, you have diminished ovarian reserve. AMH under 0.7, madam, you have low ovarian reserve. So if I were you, I would like us to go for egg donation, fertilize with your husband's sperm, and I will take it from there.
Thank you. And as we have a very similar question, I will also display it. So maybe you want to add anything. Hello, I'm 34 with 0.7 AMH, 2 cancelled IVF cycles as 0x matured, 1 long, one short protocol. Would you recommend trying another cycle with own eggs or moving into donor egg?
34 years old, you should have AMH that will allow you to have 10-15 eggs in a cycle at least. If there are no mature eggs, means you have to move on. You have to allow yourself psychologically for an egg donation, and the steps of egg donor choosing process for you were discussed. I'll be more than happy to discuss it with you in person or over the Skype. So I would move to egg donation definitely.
Thank you for this advice, and we will take and jump to the next question. For your antagonist protocols, do you use estrogen priming, particularly in 30-year-old patients in which you do not want to risk too much ovarian suppression with BCP?
When we use birth control pills, it's I shouldn't be saying names, of birth control pills, mini pills. Okay, let me put it this way: very low amount of estrogens and progesterone. Estrogen priming, it's either mini pill or estrogen priming.
Thank you for the question and, of course, for your answer, Dr. Natalia. The next question will be this one. Does fermentation quality affect the 70% implantation rate of euploid embryo transfer?
We had not long ago, Sophia, the webinar about sperm quality, where we were showing pictures of Picasso and Charlie Chaplin. Yeah. How with bad quality of sperm and demanding lifestyle, let me put it this way, yeah, they were able to achieve children when they are older than 50 years old. Okay, Emma, I have seen patients in my life with pathologic fish sperm result. I have seen men with pathologic karyotypes, and I have seen patients with high fragmentation, which were able to generate me genetically normal embryos. Not as many as in the chart that I always, show from ATA. When you are 35 years old and your euploid rate, GnRH, is 50%, if your husband has bad sperm quality, pathologic fish, you will not have 50% embryos which are good. You'll have a lower number of them. You'll have 20, 30%. And then in IVF-Spain, we perform DNA fragmentation, but it should be used as additional test. It's not crucial to determine how many genetically normal embryos you're going to generate. I think if we ask kindly Sophia, she can send you the webinar that we had about, I think it was last time, about sperm quality, yeah? So you will understand that fragmentation does not affect implantation, does not really affect euploidy rate. A lot higher impact on euploidy rate has karyotype of your husband and his fish test.
Yes, and of course, this previous webinar will be also linked with this one, but it's also available on our website. Yes, and the next question we will take will be this one. For your older patients that only get 1 2 blastocyst, would you skip the PGTA and just do a transfer, save the patient's cost? Also, if a patient pushed culture to blast stages and none made it, 5 embryos at day 3, none at day 5, would it then be best to do a day 3 transfer? Some of us are overseas, West Coast Canada for me, and embryo banking in Spain is not feasible due to the travel. Thanks for your presentation.
You know, for me, home for many years was Detroit, Michigan. And when my mom was still alive, I was like traveling 3 times to Detroit. When I was like seeing a flight Detroit, I hated this flight. So I know what you talk about. You have to, when you cannot do embryo banking and you have a doctor that develops embryos to day 5, a long culture, and there is no blastocyst. The old school that I still remember used to say, yeah, put embryos on day 3 of development because they will have a better environment in the womb than in the lab. The modern school of reproductive medicine says develop embryos to day 5, test them genetically. If you see that there is no genetically normal embryos, if you see that there is no blastocyst, do it once, maximum twice with your patient, and then allow them to move on. Advise them to do egg donation. If you have done 1 cycle and there is no blastocyst, do it once more. Take vitamins, speak to your doctor, what can you improve, especially in Canada. Canada, has an amazing insurance system. If they cover your treatment, allow them to cover 1 IVF cycle more. If you see, again, no blastocyst, then I'll be more than happy to help you through egg donation. It's not commercial, but from Toronto Pearson Airport, there are 5 flights to Madrid and Barcelona every day.
Thank you for this support you gave us. And of course, we'll take the question, which is very interesting aspect. And I would like you also to have your opinion about this. So this will be about depression. Depression is not a genetic disorder. No gene had ever been found for depression. It is an invented category within DSM based on a cluster if arbitrary characteristic voted into the DSM by committee. It is a not universal human trait. It probably indicates that the donor is artistic or sensitive, all great qualities, or that is maybe living through an adverse experience. I'm surprised you reject donors just because they achieve a diagnosis of depression and place so much weight on the opinion of a psychiatrist.
It's a very good comment. The psychiatry, it's a different, area of medicine where you cannot have results, where you have to speak to somebody, do a testing, and then you know what kind of problems you have. The light depression, where you can take modern, medication, SSRI, and after 2-3 weeks you're good, of course is not taken into consideration. There are patients with major depression disorder means it's so bad that you cannot get up from your bed because you are too weak to make it happen, and not too weak because your body doesn't allow you, because your head doesn't allow you. Thanks God, in Spain, it doesn't happen often. Through the sun, through this, that in this country, there's a very healthy lifestyle. Everybody goes to the gym 3 times a week. My family doesn't believe, my age anymore. We do not have as many major depression disorders as people have in Germany or in Sweden. Okay, but we have to rely on our psychiatrist. I cannot allow somebody who is schizophrenic or somebody who takes drugs be our donor. There is, as you say, there is no genetics behind psychiatry, but we see that children in some families are autistic, that children in some families are schizophrenic. So it cannot happen in IVF-Spain. I'm sorry.
Thank you a lot for this answer. It's great that we don't have any misunderstanding on this aspect. It is very important indeed. And by the way, we have a very similar and connected question to this one, so we will take a look on this. Do you have psychological help for egg donation? It is move on to egg donation.
When I started working with a new marketing director of IVF-Spain, it was a year ago. In 6 months, we were able to achieve a lot more than in the last 6 years. And the amazing thing that we have done together is each time when I travel, I have 24 international flights this year, and I talk, as you can hear. I like medicine. It's medicine is my true friend in this life that has never let me down. But it's a school medicine, results, numbers, rates, usually after me, there is an amazing psychologist, Portuguese background, living in London, UK. And she's doing all this support for our patients. So this is something that we can definitely offer you. We have a new psychologist applying for the job now. On the day of the first appointment, we teach you how to explain to your child where it's from, everything is about psychiatry in this case. So there are different stages of personal development according to Erikson theory of development. You have to close. There are 8 stages of development psychologically. You have to close one stage to open the new one. If you do not close one stage of development behind, and you have unsolved problems, so this will not allow you to achieve happiness. So it's super important that before age of 10 years old, you speak to your child where it's from. But you know, if you speak to somebody who is 3 years old that you are from egg donation, the child is not going to understand it. So there are beautiful fairy tales in English. When I came to this country, my daughter at this time was 2 years old, and I had to explain to her, why are we in Spain? So we were reading fairy tale about Spanish stork, that here in Alicante we have a very special stork that finds young girls here in Alicante which have a lot of eggs. They want to do this world better, and then this egg gets fertilized through the stork by the sperm of a daddy, and then the embryo is put to the belly of the mom, and there are pictures about it, okay? And you carry the child, you deliver the child, you go with the child to the doctor when the child needs, you go with the child to school when the child needs. So you have all the duty of mom. And this is the moment where at the age of 3-4 years old, through the fairy tale, you explain to your child where it's from. At the age of 8-9 years old, we recommend you to go back to Spain, either for patient Christmas meeting or for summer holiday. And then patients are coming with children. They introduce us. They go with children to our nurses, to our marketing department, to us, to the lab. Children take pictures with us, okay, at the age of 8 years old. They have family books, albums, which where they put our pictures, and they understand that a part of them is from Alicante. By the age of 10, you have a problem of egg donation, where you're from, solved. I discuss it on each first appointment this way. Our psychologist, whenever you need support, they will be more than happy to help you.
Thank you a lot for the answer and for sharing the fairy tale with us as well.
About Spanish storks.
Yes, I have also the final call for the questions, as we will be slowly finishing. Actually, now we will take a look for the question, which is not really a question for for answering now, but I think that the main part of the question.
Oh, wow.
Yeah, I know. And at the beginning, it's written that it's not about to answer during this webinar, but in the middle of this question, we have something very important. Do you offer second opinion consults at IVF-Spain? I contacted a few clinics in Spain, but ruled them out since I was told it was difficult to match my phenotype. And I would like to consider a second opinion consult if you consider this at IVF-Spain. Is it possible to send this via email, not webinar response? Thanks again for your webinar. So yeah, these are the important part of the question.
Yeah.
I think, yeah.
Okay, so I'll be more than happy to answer, you know, your question through the email. It's quite, you know, good if you want to have a second opinion. Drop us an anamnesis, and if you are from overseas, we perform a lot of Skype consultations for patients from the United States, Canada, Australia. So I'll be more than happy to support you, yeah, but I need to know a little bit more data. We usually ask for anamnesis, and then history form, and then we ask for previous protocols, and during the Skype consultation we go over this and then yeah, I'm more than happy to give you our second opinion.
Thank you a lot, Dr. Natalia. Just in case, I also put our email, as we forward everything to IVF-Spain anyway, so you can send it to us and be sure that we will forward it to Dr. Natalia directly. So
Yeah.
it's also in the chat section. You can use it, you can take it, you can write a long email, and we will forward everything. Okay, we have one more question to go.
Yeah.
And then we will be finishing. And this question is short one. And if only lets me to display. Yeah, okay. Will adenomyosis and fibroids have impact to IVF, and what protocol is suitable, please? Thanks.
Okay. Adenomyosis means it's endometriosis in your uterus wall. It has only an impact immunologically, yeah. So means that after the transfer, we give patients prednisone to make your immune system come down, and this way, adenomyosis, immunological factor of adenomyosis, is getting under control. Fibroids have an impact, not on IVF, not on controlled ovarian hyperstimulation. Fibroids have an impact on the transfer. It's super important that you have a hydrosonography performed or hysteroscopy to make sure that these fibroids have no impact on the uterus lining, yeah, so that the lining is clear. As long as they do not have an impact, you can proceed with the transfer. If fibroids are very, very big, and fibroids in the pregnancy can grow, it has to be considered, yeah, if they should be removed before the transfer, yeah. So if you are, you know, somewhere in Europe, and yeah, you need a second opinion, yeah, you know, come to first appointment, and we will be able to assess it.
Thank you, Alexis. Thank you for this answer as well. And I have also a shout out for you. Thank you.
Thank you. Thank you for waiting. I apologize for today, but I mean, Sophia kept cool, you know, blood, and she pushed it through. You can imagine there was a moment where I was like having like 2 computers open and none of them was working. So so I'm glad that we made it happen eventually.
Yes, and me, 2 telephones and headphones and computer.
Yeah.
And yeah, support live. Everything was not working with us today, but we finally made it. So thank you all for being here with us today and for your patience at the beginning and giving us a few moments so we could solve the technical issues. Of course, we are planning next webinars with IVF-Spain, so just stay tuned, and all the information about upcoming IVF webinars with IVF-Spain are available at our website. You can also subscribe to our YouTube channel or just follow us on our Facebook or Instagram. Also, you can follow IVF-Spain on Instagram and Facebook, as they really have great content there also. And if you want to add anything, Dr. Natalia, do it now.
I hope we're going to have another good webinar in July. I wish you a successful webinar next week, Sophia. Not as many challenging moments as with me. It happens to us second time, so you know we're a good team. And thank you very much for listening. See you next time.
Team of fighters, and you are all welcome to our IVF webinars next week and next IVF webinars with IVF-Spain. Have a good night. And have a good day wherever you are. Thank you one more time, and see you next time. Bye. Thank you.
Thanks. Bye.